Well, it's very similar to epiretinal membrane, where it's all about grades. So if we can see it on the scan, if there aren't any concerning features to it, so with epiretinal membrane and vitreomacular traction, there are features that let us know that the retina is not particularly happy about the situation. So in both cases, it's about traction. In epiretinal membrane, it's the abnormal scar tissue that's causing traction on the retina. In vitreomacular traction, it's the gel being stuck too firmly, and as it's trying to shift forward inside the eye, it's trying to pull the retina along with it. And so if a patient says to me, look, I didn't even know I had this. My vision's pretty good. Maybe it's not quite as good as the other eye, but it's still, almost perfect. And the retina itself is looking healthy other than that bit of tugging on it, then, that's something we may be able to watch. But if we're starting to see signs that the retina is not happy with that situation, so that would be things like seeing fluid leaking into the retina or underneath it, so swelling within the retina. It could be something called foveoschisis, which is where we can see the cell layers within the retina are being stretched apart from each other. Or it could be changes in the photoreceptors. So the photoreceptors are the light sensitive cells, and so they're the area of the retina that's closest to the wall of the eye. And we get this thing called cotton ball sign, where on the scans of the back of the eye, we can see this kind of fluffy looking material that's appearing underneath the central part of the macula. And all of those things are signs that the retina is starting to decompensate, and that if we don't do something about it, the damage is going to be permanent. Because the retina is part of the brain. So even though it's in the eye, it's physically and structurally part of the brain. And so in the same way that damage to the brain is very serious and very difficult or impossible to repair, damage to the retina can be bad enough that the body just isn't able to heal it. So we want to jump in on these things before that happens. So that's on the objective side of things, what we see on the scan. But of course, the other reason to touch these things is if it's causing problematic symptoms for patients. So, especially if it's in someone's dominant eye, for example, even if it's only very mild, it may be enough that it's distorting their vision. And so I've had patients who, I think, in one case, I had a patient who was a lawyer who was saying, look, I know that when you test my vision, I can still see the 6/6 perfect vision line on the chart, but I can't read fast enough to be able to do my job properly because there's a bit of distortion and a bit of waviness, and it's really making it a struggle for me to speed read. And I need to be able to do that in court. I need to be able to do that in the rooms. It's affecting my occupation. And so that's when we have the discussion about benefits and risks of surgery. And for this patient, it was very worthwhile, and he's thrilled to have the problem solved. Another recent patient was a competitive shooter. And it was the same thing. The distortion of the crosshairs was making it hard to hit a target at distance. And so he said, look, I'm not happy with this. I want something done. Whereas at the same time, I've had other patients who maybe they're aligned down from perfect, but they're saying, look, an operation in the eye doesn't sound great. My vision's able to do everything that I want it to, and you're telling me the scan's not looking particularly concerning. Can we wait? And in those cases, the answer for that patient might be, look, weighing up the risks and benefits, it's probably okay to just watch this for a little while. And, if it's getting worse, we'll jump in and do something about it. If it's showing signs of stability and it's never likely to get any worse, and your vision is doing all the things that you need from it, then maybe you don't need the big operation at 85 years of age compared to the 50-year-old lawyer who might not be able to do their job if they don't have the operation.
So any kind of surgery has risks attached to it. I think you'd agree. Are there any non-surgical options for someone who may be experiencing VMT?
Not for these conditions. So the three conditions we've all talked about. So for vitreomacular traction in particular, there was there was some interesting work being done to develop a drug called ochraplasma, which was an injectable drug that was designed to try to dissolve away the extra stickiness between the gel and the retina. And it just didn't work well enough. The trials basically suggested it just wasn't that effective compared to just watching and then jumping in and doing the surgery when we needed to. So that didn't really get off the ground. So at the moment, the only real treatment is surgery. But as you say, these things aren't without risk. And so, vitrectomy surgery used to be a lot higher risk than it is now. So vitrectomies, thanks to the amazing developments that we've had in microsurgical instrument technology, vitrectomy is extremely safe. It's approaching the same level of safety as cataract surgery. Which is about the safest operation that you can have. So it's a lot safer than it used to be, but we still need to be aware that in the same as with cataract surgery, it's an operation inside the eye, and there is that vanishingly small but still important risk of things that could do permanent damage to the vision. The other thing that we need to be particularly aware of with vitrectomy is, unfortunately, having a vitrectomy will always bring on cataract earlier than it was going to happen in that eye. So the warning I give to my patients is, look, if we do this operation and you haven't had cataract surgery before, there's about a 50% chance we're going to need to do a cataract operation in that eye within a year after surgery. The other 50% of people might make it to a year without any problems, but they're definitely going to need that cataract operation earlier than they were going to if we hadn't done the vitrectomy. Maybe it'll be 3 years down the track or 5 years down the track, but it'll be earlier than it would have been without the operation. So, in a way, if you haven't had a cataract operation before, you've got to understand that you're effectively talking about two procedures: doing the vitrectomy, and then sometime within a year, 2 years, 3 years afterwards, having the cataract operation. The next question that you might be going to ask is, can these things be done at the same time?
Yes,
because that's a question I often get as well. And yes, you can do a combined what we call phaco-vitrectomy, which is so phaco refers to the lens, so that's removing the lens and removing the vitreous at the same time. Again, that was quite commonly done in the days when vitrectomy surgery was risky, because it was kind of the feeling that, look, if we're going in, we might as well just get it all done in one go from a patient safety point of view. And also when the outcomes from cataract surgery weren't as good as they are now. So we're talking about an era where the expectation was that you would need glasses after cataract surgery. We're now in an era where the outcomes from cataract surgery are so good that we can reasonably assure most patients that they won't need distance glasses and maybe not even reading glasses after their cataract operation. Having the operation, having the lens removed and the vitrectomy done in the same operation can reduce the accuracy of focusing correction after cataract surgery. So if people are very motivated to be trying to get rid of their glasses entirely, and we're doing the vitrectomy for a reason where I suspect they're going to get back to very good vision afterwards, then it's important to weigh up that risk and benefit. For a patient who says, look, I've always worn glasses, I don't have a problem with wearing glasses after surgery, I'd rather just get this over and done with in one operation. Beautiful, that's great. Let's just go ahead and get both done, minimize the risk. But for a patient who says to me, look, if you're telling me I can have great vision and it's very likely that I'm going to be good enough that I can get good vision for distance and near without glasses, then that's what I want, then the risk is not very much higher to do them as two separate procedures. With enough time for the eye to heal up in between, that we can get more accurate measurements and do a cataract operation that achieves what someone's setting out to achieve in terms of spectacle independence.